Okay, good afternoon and welcome to this second plenary session of the first day of our convention. The Philippines experienced an unprecedented cases of dengue this year that prompted the Department of Health to declare dengue national epidemic last August after registering more than 85% increase in cases compared to same month of last year. But with this increase in cases, our case fatality rate has also significantly rose, and we now rank second among countries with highest case fatality rate. With measles, though globally the epidemic has been felt in most countries in Southeast Asia starting in 2018, the Philippines registered more than 100% increase in cases in the later part of 2018 and the first 2 to 3 months of 2019. And interestingly, the resurgence of these cases has tremendously undermined the ongoing preventive programs of the Department of Health. So this is a very timely topic, and our speaker will be able to enlighten us on this aspect, entitled Outbreak Management, the Counterpoint Between Measles and Dengue. At this point, I will call Dr. Sonia Salamat to introduce our distinguished speaker.
Good afternoon. Our speaker for today is Dr. Mary Ann D. Lansang. Dr. Lansang is the Chief of Party of the Collaborating, Learning, and Adapting for Improved Health or CLAIM Health project, which is supported by USAID Philippines. She is also a member of two WHO expert advisory panels, the one on health science and technology policy, and also the panel, she is also a member of the TDR Global Community Working Group, WHO Special Program for Research and Training in Tropical Diseases. Dr. Lansang is also a clinical professor of the Department of Clinical Epidemiology of the College of Medicine in UP Manila, and she is also a consultant of the Department of Medicine Infectious Diseases at the Medical City since 2004 up to the present time. Please welcome Dr. Mary Ann D. Lansang.
Thank you, Dr. Salante and Dr. Salamat, for that introduction. And good afternoon to everyone. The topic given to me actually consists of two diseases, so it's also going to be a challenge for me to cover everything in 30 minutes or 25 minutes or so. So just raise your hand if I'm going too fast. But I'm already assuming that everyone here, as members of the society, know the basics of measles and dengue, and I'm not going to deal with that really. What I was asked to do by Dr. Kawili, Janice, Dr. Jemmy, Isa, and Des, when I asked them, what's this title that you gave me? So they had to elaborate what the objectives of my session were. So these are the objectives given to me in this half hour to present an overview of the 2019 measles outbreaks and dengue epidemic, to discuss the factors contributing to the measles and dengue outbreaks, and maybe discuss some recommendations to control measles and dengue outbreaks and prevent future ones. What I'll do is quickly give an overview of the official statistics provided by the Department of Health, the Epidemiology Bureau, and we have a distinguished official of the Department of Health here, USEC Eric Tayag, if you also want to ask about the outbreaks after the session. So the overview that we are talking about in terms of the epidemic, this is, I went up to Baguio City for All Saints Day and All Souls Day. And there's a nice museum there, the Ben Cab Museum, and this is an outdoor tarpaulin of some of his works, and this is A Nation of Our Children. So this is very apt in terms of what we are talking about today, the measles outbreaks in the Philippines. As Dr. Salante already said, the measles rise in the Philippines has been very concerning. In 2006, the data we have, we had around 200 cases, but in 2018, we already had 22,000, more than 22,000 reported cases of measles. So even at that part here, this early rise in 2018, actually, this is already 2019 January. This is just a continuation of what was happening in 2018. Is that a better pointer? So this part here, okay. So here in 2018, the whole year of 2018, we already had around 22,000 measles cases reported, going up in 2019, so that by February 6, 2019, the Department of Health declared a measles outbreak in the National Capital Region, Metro Manila. So if you will look, however, at the full picture, it was not just Metro Manila where the measles outbreaks were happening. So all those figures in red that you see here, there were rises in the measles cases reported, led by Region 4A, that's Calabarzon, then followed by NCR, Region 3, and then in the Visayas, we had Region 6, and finally in Mindanao, Region 10 also showed rises in measles. So there were measles outbreaks all over the country. What about dengue? If we reviewed the epidemic of dengue, here you will see the figures for January to August 2019. A rise here in the beginning, but of course during the dry months there was a drop, and then there was again a sudden but very steep rise in the dengue cases reported. Now, the Epidemiology Bureau of the Department of Health reports dengue as probable suspect or confirmed dengue. So some of these, we don't know if they were measles. You talk about rash and measles. You also talk about rash and dengue. But of course, you as clinicians, most of you will know the subtle difference in the clinical presentations of measles and dengue. But at any rate, what was reported to the Department of Health for January to August 31, we had more than 270,000 cases. And by July, that's week 29 of 2019, there was an alert for dengue in the country. And in that same week, the National Disaster Risk Reduction Management Committee met to discuss this epidemic that was happening. If you will look at the red line, that is what the Epidemiology Bureau uses as the epidemic threshold. But clearly, in the months preceding July, there was already an excess of dengue cases reported to the Department of Health. So that by week 30, that was the following week, July 26, you will see that 9 out of the 7 regions were already above the epidemic threshold in the Philippines. By August 6, as Dr. Salante mentioned, the Department of Health declared that there was a national dengue epidemic. So what's the difference between epidemic and outbreaks? Generally speaking, when we talk about outbreaks, there are really pockets of rises, unexpected rises in the prevalence of the disease. So with measles, there were pockets like that until it increased. And then with dengue, all over the regions were showing increases in this one. So there's that subtle difference between outbreaks and epidemics, but sometimes they're used interchangeably, depending on whether you want to call attention to the rise in cases or you want to draw the attention of people away from the cases if you don't want them to panic or something like that. At any rate, the prevalence, if it's a sudden rise or an unexpected rise over what is expected from previous prevalence data, then it is an outbreak or an epidemic. So here you will see that in almost all regions except one, and that one was really just 1% decrease. But in almost all regions, there was an increase in the cases of reported dengue. The dengue epidemic for 2019 was mainly dengue serotype 3, followed by dengue serotype 1. Even in 2018, when the cases were, in 2017, there was also a rise in dengue cases. It was also dengue serotype 3, followed by dengue serotype 1. But in 2016, which was a year where we also had a lot of dengue cases, but not as much as this year, the predominant serotype in 2016 was dengue serotype 2, followed by dengue serotype 1. So what about the age distribution between comparing dengue and measles? There's a slight difference in scale in these two graphs. In dengue, the predominant one is at the age group 5 to 9 years, whether male or female. But here, the scale is different. 5 to 9 is over here. What is really affected, the age groups affected are 4 years and below. So dengue, if you compare the two, those reported between January to August this year, and measles, those reported between January to July, there were more deaths from dengue because there were more reported dengue cases. But in terms of case fatality rate, you will see that the case fatality rate for measles was much higher, over twice more than dengue. That's because you really hit the very vulnerable population, 1 year and below. You will see here the most affected groups for measles were 1 to 4, less than 6 months, and 6 to 8 months, 20%. While here, in dengue, the most affected groups, 40%, were in the age group 5 to 9 years old. Although we were experiencing this dire situation with dengue and measles, the world was also commiserating with us. Here you will see, as Dr. Salanta mentioned, there was also, globally, there were outbreaks and epidemics of measles all over, led by the Democratic Republic of Congo, Madagascar, Nigeria, but also I think we were the 4th in terms of reporting measles all over. If you will look at the number of cases reported for 2019, this was the highest reported all over compared to, let's say, way back 2006. The cases tripled almost in terms of the cases from 2018. What about dengue? This one is from the World Health Organization. For dengue, I chose to get this dengue map, which is a different sort of map. It's crowdsourced. In other words, it comes from official reports from countries, but also from reports from newspapers, from social media, and they simply mapped where all these reports were coming from. So you will see the global situation was almost like what we had in the Philippines. Although there are some countries that did not report dengue, but maybe because it was already endemic, so they weren't reporting it in the newspapers and social media. That's the kind of bias of this dengue map, but I'm simply showing you that we are not alone in this. There are even countries in the temperate zones that reported dengue. And for them, a report of 1 or 2 or even 10 is already an epidemic because they never had it before. So they're also mapped in this chart. So what are the factors contributing to the measles outbreak and the dengue epidemic that we experienced this year? And a break from that is another painting from Ben Cab by the artist Alan Ventura, already suggesting to you the factors that contribute to these outbreaks. For measles, the most important part is we do have a highly effective vaccine. With 2 doses of the vaccine, measles vaccine, or in the MMR vaccine, 97% effective. With just 1 dose of measles vaccine, it's 93% effective. So what's causing these global outbreaks and the outbreaks in the Philippines? It's really because we have lowered immunization rates. And the lowered immunization rates are because of many factors that you know, poor health services and low access to the health services. And then, of course, you know that there is civil war down in the south, and with civil war comes a breakdown in the health system, comes malnutrition and overcrowding in evacuation centers, low awareness of vaccination, and of course, the most important that we experienced because of the Dengvaxia controversy was vaccine hesitancy. The London group, the Vaccine Confidence Project of the London School of Hygiene and Tropical Medicine, for example, showed that in 2015, the confidence in vaccine, with people saying that vaccine is effective, was around 95% when they surveyed 1,500 people. But they came back after the controversy and saw that after the hula-baloo on the political downfall because of the Dengvaxia controversy, the fake news, plus also, of course, the way the possible adverse effect could happen from Dengvaxia, the way this was communicated, all contributed to the fall of the vaccine confidence to around 32% after that controversy. And of course, another contributory factor is international travel. As we know today, you can fly in and out of several countries, and you may be a vector for that one if you do have the infection and you traveled somewhere, and it so happened that the vector was also present in another place, in that other place. The mosquito, the Aedes albopictus or Aedes aegypti mosquito is present in another area, then it's possible to get that. And you may have read the news last week that there was a report of a person in Spain that dengue was transmitted through sexual transmission. And that's altogether plausible because you know that Zika, another similar virus, is also sexually transmitted. In fact, before this first report in Spain, there was another reported possible case in Italy. Also, sexual transmission was considered in that. Here you will see what we were saying about lowered immunization rates. Again, this is from WHO from September 2018 to September 2019. The highest cases, of course, were in 4 years and below, but the maroon bars here, the shaded bars in maroon here, show the percentage of people who were not vaccinated among those who were confirmed to have measles. So that's quite obvious that the immunization, low immunization, is a possible factor. Here you will see reports, consolidated reports by WHO and UNICEF from government statistics, from administrative coverage of the vaccine, and also surveys sometimes in order to verify what was being reported. And you will see that for measles, the first dose of measles, in 2007, the estimated coverage for measles vaccine, first dose, was 92%. There was a year, 2010, where it was 80%, but that increased again to 87%. But you will see here that there was another drop here, 2016, 80%, then 2017, 73%, and finally, very low, 67% in 2018. If you will look at the second dose of vaccine, the coverage was even lower. Here, even in the early years, second dose of vaccine was just 19%, and in 2018, coverage for the second dose of vaccine was only 40%. I also want to show you here the exercise by the Department of Health where they did supplementary immunization activity, or SIA. You usually do that when you note that there are outbreaks happening. And they did note that in 2018, there was already a notable increase in the measles cases. Therefore, they did a supplementary immunization activity sometime in April of 2018. That was done in NCR and in Mindanao. And you will see that for this SIA activity, which was shortly after the Dengvaxia controversy, the coverage was only 69%. And even sadder, the second supplementary immunization activity, which happened in September 2018, covering the rest of Luzon and Visayas, the coverage was only 32%. So that will suggest to you that even if you're not an epidemiologist, that sooner or later the measles cases will rise. And indeed, they rose. What about dengue? What are the factors contributing to the epidemic of dengue in the Philippines? Just like in other places, unlike measles where we really heavily focus on low immunization rates caused by various factors, dengue is a combination of different factors: the population growth, urbanization, travel, and climate change, the ambient air temperature, humidity, the water levels, etc., which affect the geographic distribution, reproduction, and feeding patterns of Aedes aegypti and albopictus, and also affects the incubation period of the dengue virus itself. Then, of course, there are considerations like poor implementation of effective control measures. We all know what the effective control measures are. The Department of Health has been campaigning for the 4S strategy forever, and yet, because of poor implementation in various parts of the country, there has been this rise in dengue. We already attributed some of the dengue cases to international travel, particularly in other countries, and susceptibility to the currently circulating serotype. As we said, there are periods where if the peak is dengue 1, then several years later, the predominant serotype might not be dengue 1 anymore. So what do we do as outbreak preparedness and response to this? This is a response that covers both measles and dengue. And here, the most important are, of course, that you have a management committee that's in charge and leads the outbreak response and also the preparedness program. And we do have the NDRRMC, the National Disaster Risk Reduction Management Committee. There's a health committee under the NDRRMC, and they do meet to respond to these kinds of outbreaks. These committees have to do early warning and the response systems, and very important, timely decision making. If the Epidemiology Bureau is already providing information that there's a rise, the committee really needs to respond early to that. The other important thing is the we need a multi-sectoral approach. The Department of Health needs to um, deal with the Department of Education, DepEd. It needs to deal with DOLE to really have a response. It needs to have partnerships with the private sector so that we have really a coordinated response. Very, from my biased point of view as an epidemiologist, I think that one backbone of the preparedness and response to an outbreak is an effective surveillance system, an effective information system that tells you, that carries out outbreak investigations, does risk assessments. It tells us, advises us on where the immunization target should be, and it helps us predict the trends of the disease, trends for the measles, trends for dengue. A very important component, of course, is people like us in the Philippine society, timely and responsive healthcare providers who are trained well in managing cases of measles and dengue, and of course, good laboratory support and infrastructure for disease confirmation. For dengue, the reported cases that we mentioned a while ago, only 50% of that are really confirmed dengue cases by either virus isolation or PCR. Of course, we need adequate mobilization of human, financial, and other resources, and very importantly, good information, education, and communications, including responsible risk communications. We already learned our lessons well with the Dengvaxia controversy, that risk communication is so important, careful risk communication. So, what about measles-specific response? The previous slide showed you a common response, but there's also measles-specific response. This is really from the recent ID Week, the convention of the Infectious Diseases Society of America, and there's Dr. Sanyel right there, writing on the board, and I think we have a similar board now for PSMID, where they wrote what they wanted, and somebody wrote there, "Do not get measles." Very important. Dr. Panaligan says to protect and save lives. Dr. Salante says there, because that's the right thing to do, even though his spelling is not right. And Dr. Sanyel, in the last corner there, said, to help save the world, because we're not just the only ones affected. The whole world is affected. So what's the measles-specific response there? There's an outbreak response immunization nationwide. And the Department of Health called it pinaigting ng pagbabakuna, which is really reach the last person, close the last mile. So accelerated immunization plus supplementary immunization activities. And after the outbreak, you also continue to immunize, identify children with missed doses of EPI vaccines, do school-based immunization, and beyond 12 years old, do the second dose, provide the second dose of measles. Another thing that's very important for the measles-specific response, since the case fatality rate for measles, at least in the Philippines, is higher than dengue, there should be adequate clinical management. And for this, early clinical management is important, and vitamin A administration. And in our healthcare settings, early identification and isolation of patients with known or suspected measles, cohorting of measles patients, airborne precautions, because from 4 days after the rush, you're still contagious. Then I wonder, there was a lecture last year in the PSMID convention about immunization of healthcare personnel, and I wonder how many have complied with the recommendations of PSMID on immunization of healthcare personnel. Measles is required, unless, of course, they have proof that they have had measles in the past. And, of course, in infection control, routinely promoting and facilitating respiratory hygiene and cough etiquette. I just wanted to show this basic reproduction number, which is an epidemiologic concept that tells you how much a case, uh, one disease can cause in terms of reproducing and um, infecting other people. Here, over here, you see that the basic reproduction rate, the R naught for measles, is very high. The estimates are between 12 to 18 infected with just one case. Here, the summary from various sources pegs it at an average of 15. While for dengue, where's dengue? It's over here. An average of 1 to 6 are not. And here they pointed it at 5. So in terms of contagiousness, in terms of healthcare response, we really have to make sure that the measles cases are really cohorted and isolated so as not to spread further. What about dengue? What is the dengue-specific response, aside from the generic ones I mentioned? You can see here that for dengue, it's rather complicated because you have to monitor a lot of factors, disease surveillance, of course, but also entomologic studies. Where's the entomology here? Vector surveillance, viral surveillance to know what's the circulating circumstance, serotype, syndromic surveillance for those who are suspected to have dengue, and weather changes, rainfall, other parameters for climate surveillance, and even media surveillance to know what is being reported out there. These will all contribute to an integrated alert algorithm. Here are some other specific vector control. How many more minutes do I have? 5 minutes. So what I'll do is just run through the vector control programs. You already know the 4S campaign of the Department of Health to control the Aedes in terms of chemical control, biological control, ovid traps, and of course, environmental cleaning and management, which will not just be carried out by the Department of Health, but in fact, the community must be mobilized. The private sector must be mobilized. NGOs must be mobilized. We also need to monitor insecticide resistance routinely so that we're sure that our chemical control is effective. And finally, we also need to predict future outbreaks through various means. And I just want to share with you this MOS, Dengue Model Satellite System. This was shared by Dr. Alejandria. She attended a meeting in London on outbreak response and preparedness, and that meeting was about research in relation to preparedness and response. And you will see here that the UK Space Agency that funds this, along with various groups, almost 10 groups, including the London School, an engineering company, WHO, etc., UNDP. They developed a system to model and predict when a dengue outbreak or epidemic is coming, 8 months before it comes. So this is really clever, and this is how it works. They have hydrologic modeling as well as mathematical modeling to predict when the dengue outbreak might come. Now, this has been applied now to the Philippines. The London School, which was a partner of the MOS system, has now applied it in the Philippines in cooperation with the Epidemiology Bureau of DOH, RITM, and the University of the Philippines, Manila. This slide is courtesy of Ms. Ava C. from RITM through the help of Dr. Des Roman. So what they did is they got data, historical data from the Department of Health, and they are now currently studying this in order to be able to understand how the trends, disease trends in the Philippines. And you can see here that from their historical data, they can already say what this average serological conversion rate is per year, which is 17%, and of course, much higher already in the adult age group and increasing in the younger age group. They have mapped where the serological conversion rate is different So for different parts of the Philippines, you don't have the same serological conversion rate. So you cannot make a blanket statement that here you need to do this. You need to really do surveillance on the ground with your community to report where dengue is going on. So in the National Capital Region, the SCR is 20%, while in CAR, the Cordillera Autonomous Region in the north, the SCR is only 6%. So there's variability in various places, and this consortium is studying this kind of prediction model. So what about dengue vaccine? This is probably my last few slides. Does it have a role in outbreak response? My opinion is it does not have a role in an outbreak response, but it certainly should be considered as a strategy for overall prevention and control. The aim, as we know, is we want to reduce susceptibility for all dengue serotypes and among eligible individuals only. So at a certain threshold, which I don't know yet, somebody has to study that threshold, an effective vaccine, we want an effective vaccine that can reduce the level of susceptible humans who serve as an effective primary reservoir for dengue virus. As you know, not all dengue people who have dengue are symptomatic, and yet they're walking around, the mosquitoes are there, and the mosquitoes bite them, and it's transmitted to others. So we really need, in the long run, a vaccine that will help us reduce that as well. The good news is for dengue vaccines, we have leading products and candidates. We already have Dengvaxia, but we need 3 doses for that, so that for an outbreak response, we really cannot depend on it. But on the whole, it can be used for prevention and strategy, but only for those who are seronegative, as we knew retrospectively or in hindsight. But there are also exciting developments. The Takeda vaccine only needs 2 doses and showed good response, and it suggests good response in seronegative individuals. Therefore, the barrier to pre-vaccination testing may no longer be a problem for the Takeda vaccine. If you want to read all about it, it was just released, the part 1 results of the phase 3 randomized control trial in the New England Journal. And Dr. Lulu Bravo was one of the co-investigators for this randomized control trial. Perhaps the most exciting candidate is the live attenuated tetravalent vaccine developed by the U.S. National Institutes of Health, and based on their formulation, the Butantan Institute in Brazil is developing it, and Merck has partnered up with Butantan Institute to further develop that. And the ongoing phase 3 trial with this vaccine shows that in 1 dose might be effective. So stay tuned for developments along that. There are other dengue vaccine candidates, but these are the 3 that are almost there. So recap, what we did was we reviewed the measles outbreak in the Philippines this year and the epidemic outbreak. We discussed the factors contributing to these. We listed the common measures, but we also differentiated the main interventions for measles and the dengue outbreaks. In passing, I again want to show the sad painting of Ben Cabrera about a nation of our children, and he quoted one of our distinguished statesmen, Jose Diokno, who said, if we can but release the creative energy of our people, then we will have a nation full of hope and full of joy, full of life and full of love. A nation that may not be a nation for our children, but which will be a nation of our children. I would like to paraphrase that and say that we want creative energy of our people to control the outbreaks of dengue, measles, polio in the Philippines, because it's for our children. And here's that other outdoor art in the Ben Cab Museum that shows this child reaching out to that mobile there. And the title is Abot Kamay. In other words, ang karapatan ng kabataan ay dapat abot kamay lamang. In other words, the rights of children should be just within their reach, just the shorthand of a child. It should be within their reach. With that, thank you, and these are my acknowledgements.
May we ask our chair, Dr. Ronjean Solante, and co-chair, Dr. Maria Sonia Salamat, to award the Certificate of Appreciation to our speaker. Let's give them a round of applause. To introduce the third plenary session and speaker for today, may we call on stage the chair, Dr. Enrique Tayag, with the co-chair, Dr. May Angela Pelayo.
Nandito, meron naman dito. Hindi ko lang alam kung paano papalit tayo.
Hello, good afternoon, everyone. Welcome to SOGI 101. Okay. So you'll be introduced to terms like gender fluid, LGBTQ+, okay, pansexual, okay, gender expression, sexual identity. Okay, what are these? What's the difference? PSMID decided to include this topic because it has been shown that discrimination and stigmatization are some of the drivers for our epidemics of infectious diseases, beginning with HIV and AIDS. And so therefore, it is very important for all of us this afternoon to understand exactly what SOGI is, the context, its implications, and how we can stop discrimination and stigmatization. How about a round of applause? SOGI 101 is hereby presented. And to introduce our speaker, we have Dr. Maya. Maya, come on stage. Round of applause, everyone.
So our speaker for this afternoon is currently the medical director of the Sustained Health Initiative of the Philippines Incorporated, and she's also currently the medical director of the SHIP Clinic. She's also a consultant in St. Patrick's Healthcare System and United Doctors Medical Center, Manila. She also received the International Investigator Award in the IDW Class 2013 for her research on the changing epidemiology of the HIV-positive patient before and after accessible antiretroviral therapy, areas for intervention in the time of a national epidemic. So, ladies and gentlemen, presenting Dr. Caterina Tolentino Leritana.
Magandang hapon po sa ating lahat. I'd like to thank PSMID for the opportunity to share with you a very important topic that hasn't been discussed so much, but I think should be a must for all healthcare providers. Ika nga ng sabi ni Dr. Tayag, ito ay very important because of the possible ramifications in infectious disease. So my topic today is SOGI 101. Okay. So, first of all, hi, I'm Kate, and my pronouns are she and her. What about you? So, answer in your heads. Are you familiar with this form? So, this is actually our consent form for the HIV test, also known as Form A. This has undergone multiple revisions, and the most recent revision is this part. Are you familiar with this section? Do your intake forms in your clinics and hospitals reflect this? Yes? Do you have areas for sex at birth and identity? Okay, very good. So I want to talk about the following. The reason why it is important to give importance to sexual orientation, gender identity, and expression is because of minority stress. So minority stress has been found to not only affect mental health, but also physical outcomes. Small instances of microaggression on daily life, small prejudices can actually have significant outcomes in health. So, is there still a need to define? The answer is yes. There is evidence of physical, mental, health inequities, and healthcare disparities to access. And however, the magnitude of these disparities has not been fully determined yet, owing to lack of routine collection of patients' SOGI data. In the Philippines, there is a paucity of information. So most of the data I'm going to show you today are actually international data. There is evidence of improvement in outcomes if SOGI is given recognition. Surprisingly, many of the studies of SOGI information has been reported by our healthcare physicians in the emergency department. So in a small study done in the US, 80% of ER clinicians believe that patients will refuse to provide SOGI information. But when the patients themselves were asked, only 10% of LGBTQI patients will report that they would refuse to provide this information. So in fact, patients want us to ask about their sexuality and gender. They believe that this is important for their doctors to treat them as a whole and for them to receive holistic care. So therefore, it is incumbent on us healthcare providers to make every healthcare interaction a space of trust. Transgender women have known to have very high levels of postponing medical care when sick or injured due to discrimination reported in 28% of about 70,000 transgender patients who were surveyed in 2008. 48% report that they are unable to provide for themselves for healthcare. What were the significant hurdles to their accessing of healthcare? 19% reported that there was refusal of their care due to transgender or non-conforming status, while a whopping 50% stated that they had to inform their healthcare professionals on how transgender healthcare is supposed to be. So if medical providers were aware of the patient's transgender status, the likelihood of that person experiencing discrimination actually increased. I'm going to tell you some stories about healthcare disparities among our sexual minorities. So this is a report of the Human Rights Campaign Foundation in 2016. I'm going to present about 3 stories. A transgender woman waiting for her first checkup in years said, "When I walked towards the women's bathroom in the waiting area, the receptionist jumped up and told me to use a McDonald's restroom down the street. I felt like leaving and never going back." A gay man hospitalized for lung conditions said, "After I mentioned that my husband would be visiting me, the staff had been very friendly turned very cool, and I saw a lot less of them, even when I really needed help. A lesbian mother, after the birth of her first child, said, "I couldn't believe it. As I walked back to see my partner and our newborn, an employee stopped me and asked who I was. When I said, 'I'm the other mom,' she rolled her eyes and walked away, saying, 'I don't believe this.'" In the Philippines, the World Health Organization policy brief on transgender health and HIV in the Philippines stated that the transgender population had no clear separation of health services between them and the MSM community. There was perceived discomfort when they were tried to access healthcare services because they became identified as men in the healthcare setting. They were not aware of any specific program or guidelines that addressed the health of transgender people in the Philippines. There was also lack of information on transgender health in medical schools' curricula. So what are we going to do? Let's start with cultural competence. So cultural competence is defined as the awareness and adequate responsiveness to patient populations with cultural factors that may affect healthcare, including language, beliefs, and behaviors of healthcare providers. This enhances the physician-patient interactions and is associated with improvement in outcomes and satisfaction with care. Let's start today by knowing more about what we don't know. Okay, so ito na po yung ating meat of the lecture. SOGSC. So these are the meanings of the acronym. Now, I want you guys to answer these questions in your head once again. Back when you were born, what did the doctor say? It's a boy, it's a girl. Number 2, right now, how do you see yourself? Number 3, how would other people describe how you look, dress, talk, and carry yourself? And lastly, who are you romantically attracted to? We're going to return to these questions at the end of my talk today. But let's begin with sex characteristics or sex at birth. So these include primary and secondary sex characteristics. The primary sex characteristics are usually your biological sex determinants. They say that sex is determined by the presence or absence of a Y chromosome, the types of your gonads, sex hormones, internal and external genitalia, and your secondary characteristics are your muscle mass, hair distribution, and stature. So yan, most women are 46XX, most men are 46XY. Previously termed as hermaphroditism, this is now called as intersex. So intersex is the I in LGBTQIA. So people born with physical, hormonal, or genetic features that are neither wholly female or wholly male based on the following. Kaso nga lang, nature does not dictate when does male characteristics start and intersex begin, and vice versa sa female. So intersex is actually a label put upon by humans. Who's human? The doctors. Intersex is a cultural phenomenon on the background of biologic science. Next, let's go to the next 2 letters. GI, or gender identity. It is an internal characteristic, a deeply held sense of one's own gender. It is what is in your head. It is not visible to others, and it does not need to match your sex assigned at birth, nor your external appearance. We aren't born with gender, we are born into gender. So some terminologies, just browse through it, but we are going to answer some questions later using these terms. So na-mention ni Dr. Tayag itong mga to kanina. Okay, remember our, ano bang subject yon? Trigonometry, cis and trans, yes? So cis appears on the same plane, so if there is a match with your gender identity, same plane cis, And trans is opposite. Okay. So non-binary, someone who does not identify as exclusively male or female. So wala siya doon. Gender fluid can move from one spectrum to another at different points in time. And gender queer is in between. I think this is better seen in a picture. Okay. So think of womenness and manness, napakalinan, as a spectrum. So if you have a lot of womanness in you, if you feel that you are more woman than man, and you were born as female on the left side, then, so sex characteristic is female, gender identity is female, on the same plane, therefore, cisgender. Okay. If you were born male, but you identify as female, you are transgender. Okay? Nandito pa lang tayo, ha? We're not yet on our outer. Next, opposite side, born female, but identifies as male, is transgender. And if you're born male and identify as male, cis. Oh, di ba ang dali? It's so easy. Okay. What about someone who says they are not either, as mentioned a while ago, who does not identify as either man or female? Non-binary. Okay. I don't want to be classified as only two types. What about someone who at this moment identifies as female, but for the last 2 years, I felt male? Gender fluid. Fluid. I'm somewhere in between. What's the last option? Genderqueer. Okay, so they said that before, a long time ago, the term queer was found as derogatory. So if you watch old movies, usually bad word yung if someone calls someone else queer. But today, nowadays, the young people are taking back the label and owning it and claiming it and are proud to say, I am queer. Okay. Now, let's move on to gender expression. Gender expression is how you demonstrate your gender based on traditional gender roles. It is what you see. It's observable. It's how you look, you dress, you talk, carry yourself, act, behave, and interact. Okay. Ayan. So if you have more feminine in you than masculine, then you are feminine. Remember, this is regardless of sex at birth, regardless of gender identity. Okay? Itsura lang niya. External, feminine. So for all you know, this is actually a male at birth. Kamukha lang niya si Taylor Swift. Next, if you have more manly expression, you are now masculine. Who's this? It's a paper doll. Kamukha siya ni Justin Bieber. And if you have some and or equal parts of feminine and masculine, the term is androgynous. Okay, whether male or female, if you look almost the same as them, androgynous. And may bago akong natutunan, gender neutral. And the key fashion statement of a gender neutral is this outfit, a onesie. Because how gender neutral is a onesie, mapa boy, mapa girl. The point is, they get none of the stereotypes of each gender. And that's their symbol. Okay. How exciting, so many new terms. Now, let's go to sexual orientation. Sexual orientation deals with attraction, romance, who you are attracted to, and this is on the basis of how you identify as. So here we need two factors, your gender identity and who you are attracted to. So if you're a male, you think you're a male, buddy. You think you're a male, and you love a female, what's your sexual orientation? What are you? I am straight. Ito yun. Okay? So here, I'm orienting you to the flags. Not only do we have new names, new symbols, we have flags. Okay. Now, if you're male and you love another male, what kind of sexual orientation do you have? Okay. So I heard some people saying homosexual. So later on, we'll talk about acceptable terms and non-acceptable terms. But for now, the acceptable term for this relationship, this inclination, is gay. If you're a female and you're attracted to a female, you are a lesbian. If you're a female and you like both men and women, you are bisexual. It's not a phase. If you're a male and you don't love anybody, you're not attracted to anybody, what are you? Asexual. Or no love life. Na joke. Okay. If you're female and you like all, male, female, bisexual, asexual, you are pansexual. I love any. Okay? Eto. So, ang symbol nito is, ano siya? Transgender man. Transgender, naguluhan din ako. Transgender man, itong symbol, okay? Born female, identifies as male. Okay? Para clear. I fall in love with a woman. What kind of orientation do I have? Yes. Tingnan mo lang ito. Yun lang. Yan, tingnan mo. Very good. Okay. Next. I'm a transgender man. And I love a transgender woman. Again, look at the orange bars. Straight. Okay. It's here. It's not here. It's here. Okay, now. Have you memorized it all? Quiz tayo. Okay. Now again, answer these questions. You may have changed your answers. That's absolutely fine. But what is the point of this? We all have our SOGI. Hindi lang yung LGBTQIA ang may SOGI. Even the cisgenders, the straights, have SOGI because you have all of these. So do you know what your SOGI is? Yes? Okay, now, terms to avoid. Hermaphrodite, so it's now intersex, or the particular disorder of sexual development that the patient has. So they tend to shy away from the term homosexual now, and they prefer gay or lesbian. Sexual preference is now sexual orientation. Transgendered or tranny should be transgender woman, transgender man. Gay lifestyle is LGBTQ people in their lives. Sex change should be gender affirmation surgery. And it's not special rights. Because patas lang naman tayo, di ba? Equal rights. Right? Okay, tips. Very important. Sorry, super dami. But did you know that allies, straight allies, are also part of the LGBT dami na letters, so you're the first A. We're the first A. Kasi yung second A is asexual. So, number one, especially for transgender patients, so we don't offend. You can't tell if someone is transgender just by looking. Don't make assumptions about a transgender person's sexual orientation. If you don't know what pronouns to use, listen first. Maybe someone will call them. Don't ask a transgender person what their real name is. It causes stress. Ask them, what do you want to be called? What's your pronoun? It's so weird, no? What's your pronoun? Anyway. Understand the difference between coming out as lesbian, gay, or bisexual and coming out as transgender. Be careful about confidentiality, disclosure, and outing. Outing is something that is that person's own prerogative. You do not out them. And you do not force them to come out because of your discomfort. They will come out on their own time. Kahit isipin mo na, alam na ng buong mundo, it's his or her thing to do. Respect the terminology a transgender person uses to describe their identity. Be patient with a person who is questioning or exploring their gender identity. Understand that there is no right or wrong way to transition and that it is different for every person. Don't ask about a transgender person. Ang dami kasi nagtatanong, ito yung unang tanong, di ba? So someone sees a transgender patient, so nag-ano ka na ba? Yun ang unang tanong niya, di ba? Nagpalit ka na ba? No, you don't ask that. Kanya yun. So don't ask about their genitals, their surgical status, or their sex life. Avoid backhanded compliments like, I always hear this. Sayang, ang ganda-ganda mo pa naman. Bakit ka naging trans man? That's not a compliment. That's an insult to them in their being male. Okay? Challenge anti-transgender remarks or jokes in public spaces, including LGBT spaces. Support all gender public restrooms. Help make your company, your clinic, your hospital gender inclusive, not only trans inclusive, gender inclusive. At meetings and events, set an inclusive tone, listen to transgender people, and know your own limits as an ally. Okay. So for those who are interested in knowing how to make their healthcare spaces a safe zone, we can look at the Healthcare Equality Index. They have certain criteria to score. So what they do is, they go around the US and they score the hospitals in the following criteria. And then they put out an annual report saying these hospitals are the most gender inclusive. And of course, for those clients who are LGBTQ, they would prefer to go to these hospitals. And lastly, so this won't be SOGI unless I talk about the SOGI Equality Bill. A little history. In 2000, it was first filed by Senator Miriam Defensor Santiago and Eta Rosales. It passed the third reading in the House, however, it stalled in the Senate. It was refiled by the same senator, and in every Senate until her last term, it is the longest languishing bill in the Senate. So in 2017, House bill was filed by Kakabag-Aud, Geraldine Roman, and it's about the anti-discrimination bill that passed the third reading uncontested. In May 2018, the Senate counterpart was filed by Senator Hontiveros. It is still languishing in the Senate, and we fear it will die in the Senate. This September 11, the President said that he will certify as urgent the anti-discrimination bill, but not the SOGI bill. The end. So, if our policies are limited, we'll just do our work as individuals using the following: practice empathy, give kindness, act with compassion, create safe spaces, and provide support. Maybe if our individual efforts are combined, it may be more powerful than a policy in the future. Thank you for your kind attention.
To present the certificate of appreciation to our speaker, may we call on the chair, Dr. Enrique Tayag, and co-chair, Dr. May Angela Pelayo. may we request the chair, Dr. Remedios Coronel, and co-chair, Dr. Evelyn Rojas, to open the fourth plenary session and introduce our speaker.
Good afternoon. We will now have the fourth plenary session for this afternoon. Health is a high priority for any society because infection is one of the leading cause of disease globally. In the hospital, a hospital-acquired infection leads to a significant additional morbidity, mortality, and economic burden. Effective infection control practices makes a greater percentage of reduction of hospital-acquired infection in the developing world. Infection control practices is an essential component in reducing antimicrobial resistance. It's an armamentarium in antimicrobial stewardship. And as I've said, an essential component of a better functioning, healthier, and happier society. Now may I call on Dr. Evelyn Rojas to present our speaker.
Thank you, Dr. Coronel. Good afternoon. It is my honor to introduce the speaker for the fourth plenary session. He is the chair of the Department of Medicine, University of the East, Ramon Magsaysay Memorial Medical Center, an assistant professor of medicine, College of Medicine, UE, RMMCI, the assistant head for training and research, section of infectious disease, St. Luke's Medical Center, Bonifacio Global City, the chief of section of infectious diseases, SLMC BGC, a medical specialist too, and the head of the section of infectious diseases, Department of Medicine, Dr. Jose R. Reyes Memorial Medical Center, currently the Vice President of the Philippine College of Physicians. He was a past president also of the Philippine Hospital Infection Control Society. Let us all welcome our speaker, our dear President, Dr. Mario M. Panaligan, to talk about controversies or avoiding complacency of infection prevention and control.
Salamat, Dr. Roas. Salamat, Dr. Coronel. So this is an additional disclosure. Of course, I give lectures to some pharmaceutical companies. Yung picture ko, yan yung bago, no? Parang chillax lang. No? Siyempre complacent, so parang chill lang tayo. But of course, this is one good guy that we all of us know, the known father of infection control, who actually spearheaded the principle of hand hygiene. So he worked as a house officer in obstetrics ward, observed higher frequency of maternal death due to puerperal fever in one clinic handled by doctors and medical students, compared with the other, which was handled by midwives. So mga doktor noon talagang hindi marunong hugas ng kamay. And so what he did was, of course, observe, you can see that definitely has documented there's a higher mortality rate among those pregnant, postpartum, who actually had maternal fever and then eventually died. And so he made this observation that many of those doctors were actually coming from taking care of dead patients. So So hindi nga naghugas sa kamay, kung naghugas man kulang din. So he actually gave this instruction and uh, required them, no, to wash with chlorinated solution. And you can see that here there's a drop, no, in the maternal mortality rate after that when he imposed it. And therefore, there's a time that it all started and hand hygiene was implemented in all cases, particularly when we are handling patients, particularly post-operative or even post-procedure patients. So at the end of the presentation, the audience must be able to understand the importance of infection control, become familiar with the valuable means, and avoid the complacency in infection control. So when we talk about infection control, certainly it's a practical solution designed to prevent harms caused by infection. Certainly, it's not only for our patients, but also for other persons that we're taking care with. Pati tayo, syempre, importante na malaman natin that this can also help us in terms of preventing infections like what we're having now, especially with the outbreaks. Of course, complacency, certainly as I've said, is chillax lang, a feeling contentment or self-satisfaction, often combined with the lack of awareness of pending trouble or controversy. So you can see the danger there. You can imagine, of course, if you become complacent when you're taking care of patients, certainly that can lead to lots of disastrous results, and that can lead to clusters of infections and later on outbreaks. And we're not just talking about the hospital setting, but even in the community setting as well. So, ito, favorite natin, pag nagte-text tayo, mabilis. So, pwede na yan yung you're welcome na wala yung RE, Kasi pwede na rin, naiintindihan rin na iba yun na yun. But certainly, when we talk about infection control, we have to make sure that what we do is correct and what we do is appropriate even in selected settings or even in specialized settings. So, looking at this figure in a conference, yes, kung namamagana nga yung kamay, bakit doon pa insertan, ng IV line, Yes, it can still work, but apparently, we should always remember that that can cause a problem later on. So, IPC, or Infection Prevention and Control, is a scientific approach and practical solution designed to prevent harm caused by infection to patients and health workers. It has a unique position in the field of patient safety and quality universal health coverage, since it is relevant to health workers and patients at every single healthcare encounter. So that figure will tell us how difficult it is to handle patients who are admitted in the hospital. And you can see that there are lots of sources of infections, particularly among those admitted in the critical care units, those with devices inserted. That can definitely be a port of entry for your patients. So these healthcare-associated infections definitely are quite common, and that can spread to vulnerable patients in the hospital, even to us who are susceptible, especially if you're not protected. For example, if it's a vaccine-preventable illness, then if you get exposed to it, then definitely we can get the infection ourselves. And looking at healthcare workers, 5.9% of home healthcare workers report that they were diagnosed with an occupationally acquired infection caused by MDRO. And this is a good finding that the nurse's bag can serve as a potential reservoir for bacterial organisms, with 83.6% of bags testing positive for human pathogens, of which 15.9% were MDRO. So this is just a figure that will show us, na-discuss kayo ni Dr. Lansang yung outbreaks na meron tayo recently, and that can definitely occur worldwide. Okay? And that can happen primarily in every area, particularly the ease of travel. And in 2018, so listed here are the 8 health issues that made headlines in the Philippines, 4 of which are infections. Of course, this include TB, dengue, measles, and HIV/AIDS. Kung sasama natin cervical cancer, that's highly associated human papillomavirus infection, which is a sexually transmitted infection or a virus. So how does an infection occur and how does it spread? So ito yung favorite figure ko noon, no? Especially when I was still when I'm, of course, the president, as well as working with Philippine Hospital Infection Control Society, the chain of infection. So certainly, the main ports there, of course, the main source, of course, in, uh, the, the patient, which carries infectious agent, and that can actually be our reservoir, and that can easily be transferred to other patients. And remember that there are several modes of transmission that we have to be familiar with, and therefore we have to know what to do to prevent, acquiring and preventing the spread of an infectious disease. Of course, yung mga outbreaks, certainly that can go back, that can reemerge, and again become a problem later on if you don't do something. And let me just show you, of course, those problems that have become problems and would remain a problem if you do not do anything, especially, particularly with this one, which is a major health problem, being the sixth major cause of death in the Philippines. And there's definitely increasing number of MDR-TB. Now, globally, Philippines is now number 4, and it's transmitted airborne. Of course, itong measles, and this has become an outbreak recently, and almost 15 years ago, we were able to somehow decrease or even eradicate this particular problem. However, because of not only because of the vaccine itself, but because of the non-familiarization on how it can actually spread rapidly, and that caused the clusters of infections early this year. And you can see that in April, there was declaration of an outbreak. There's a declaration of an outbreak early this year for measles. And you can see that as of August 31, 2019, there were around 34,950 measles cases and 47 deaths. Siyempre si dengue, kasama dyan. And definitely this is a year-long disease, and outbreaks can actually occur every now and then. Especially this year, there are around 622 deaths reported. And you can see that that's reached more than the epidemic threshold in August. Okay. Siyempre, ito rin, and definitely it has been reported that HIV spread fastest in the Philippines in the Asia-Pacific region. And you can see that now there's around 35 new cases diagnosed every day. And you can see that for the past several years, for the past 3 decades, pataas talaga yan. And we cannot predict, or we do not know how will this stop, the increase or in the rise of the number of cases, primarily because of the non-familiarization, mainly how it's actually acquired. Most of the cases are between 15 to 24 years old. And you can see that even in females, tumataas na rin recently. Okay, siyempre ito, polio outbreak. Siyempre ito yung pinaka mainit na issue the past 2 quarters. And it's been declared an outbreak recently, and we now have 4 cases. Certainly, it's a lethal infection, can cause paralysis, and can spread from person to person. Okay. Of course, ito, siyempre, this is of course a problem that can still continue if we don't actually control the use of antibiotics. And certainly, antibiotic use is a major reason why organisms become stronger. And that's why they become superbugs. And they can spread easily. This was presented earlier by Dr. Keith Kay, emphasizing, of course, the rise of the number of resistant gram-negative organisms in the Philippines, particularly Acinetobacter baumannii. And this was also presented earlier that in 2050, you can see that around 10 million will die because of antimicrobial resistance. Sorry for this. This is just an illustration how selective pressure occurs, primarily because of the use of antibiotics. And there are also other drivers of antimicrobial resistance, especially in the Asia-Pacific region. Mahilig tayong kumain, di ba, ng mga baboy, baka, chickens. Certainly are given feedings that actually contain antibiotics, and that can induce drug resistance. And that can, of course, cause an increase in that antimicrobial resistance that can spread easily or can be acquired by humans, and that can spread easily. So certainly, WHO has given out a guidelines on use of medically important antimicrobials in food-producing animals. And you can see in this figure how antibiotic resistance spreads. No? So, siyempre, kasama tayo. If you look that our hands attending to our patients can carry the organisms, and that can easily be transmitted or that can cause problems in vulnerable patients. But similarly, if you actually eat food from food-producing animals, and these animals were given antibiotics, no? Certainly those animals can actually carry organisms that are resistant and then can be acquired by humans, causing MDRO infections. So what's next? Siyempre yan, no? Infection control. No? Pero kanina nga, paano kung complacent tayo? No? So, but definitely, let me just show you, of course, the different ways on how we can actually prevent, no, the spread of infections. Number one, siyempre sa hand hygiene. Ito the main mode, the main means of preventing spread and acquisition of any kind of infection. The most cost-effective means preventing even healthcare-acquired infections. So, looking at the summary of the evidence of hand hygiene as a building block for infection prevention and control, no, they recommend, of course, National IPC Monitoring Evaluation Program should be established to assess the extent to which standards are being met and activities are being performed according to the program's goals and objectives. And of course, they highlighted hand hygiene monitoring with feedback as a key performance indicator at the national level. So, dapat hindi lang individual, but even nationwide, or even everybody should actually practice hand hygiene. Panel recommends that materials and equipment to perform appropriate hand hygiene should be readily available at the point of care. And good that many hospitals now have put hand hygiene solutions, but certainly there's still a need, no, to enhance such practice among all healthcare workers. No? And this is just a list of different isolation precautions, of course. And this, of course, the IPC procedures, the healthcare setting. You know. Just have to highlight, of course, bundles of care that could be looked at, whether they are applicable and can be implemented in the hospital setting. And of course, other IPC measures include surveillance, occupational-related management, outbreak investigation and management, and antimicrobial stewardship. So this is just an illustration of breaking the chain of infection. So you just have to be familiar on how the organism is transferred or acquired, and spread to the patients. Of course, there are lots of opportunities where we can improve on. But however, we certainly have lots of missed chances on how we can actually do it. And certainly this is another big issue when you talk about infection control. Compliance. Paano ba natin i-convince? Paano ba natin sabihin? Kahit sa mga ibang doktor na ay maghugas ng kamay. No? And certainly that has been documented that there's really lack of correlation between even the level or the knowledge of infection control with compliance, no, among nurses working in, of course, in healthcare settings. No. So these are some tricks and tricks. So millennial ang peg ko, kaya BFF, bugs forever and forever. No? But actually be focused and familiar. No? BFF. Be focused, know what you're doing, and be familiar with how you're going to do it, knowing how these organisms are transferred or acquired, and know what to do. HHWW. Holding hands while walking. Actually, hand hygiene while working. So while we are working in the hospital, definitely we have to wash our hands. Beware, be aware. Okay. So, A, B, C, D, E, precautions. A, airborne. Of course, C, contact. D, droplet. Yung B dyan, blood and body fluids. Yung E, et al. everything, you have to become familiar with how these infections are acquired and transmitted. So this is just a composition that I made when I was a president, no, of the Philippine Hospital Infection Control Society. Sabi ko kanina kay Dr. Rojas, kakanta ako eh. Kaya lang wala nang oras, 3 minutes na lang eh. But definitely, I just have to highlight, of course, this part, no, in the composition, no. Walang pa subaling ating ididiin, kalakasang walang hanggan ang ating ngitiin. Mga karamdaman, sakit na malubha, madaling maiiwasan at mababantayan. So sa ating mga kamay, doon nakasalala no? Isa pa, with feelings. But let me show you, of course, a video of a film that I enjoyed seeing, of course. This is actually, if you saw this film and liked it, I liked it so much also. This is the film, of course, by Maine Mendoza and Carlo Aquino. If you saw the film, then ito yung highlight ng film, the end of the film, no? Carlo Aquino is a deaf person, so they just communicated with hand signs. And what happened, of course, they became in love with each other. And there's one request from the deaf person, who is Carlo Aquino, to ask Maine to teach him to dance. So a deaf person dancing, and you can see how he did. Even if he is a deaf person, he was able to dance. And you can see later on, during the dance performance, how Maine actually supported him. Can we play it? Yeah? Actually, yung sign na gano'n, that's a big dream actually. So, 100% application of infection control to prevent infections definitely is a big dream if we remain complacent in terms of applying what we know for our patients and for ourselves. So just some key points. Have a focused mindset on well-being and continue to pursue patient safety and control of infections with practical and effective preventive measures. With that, just remember, be alert and of sober mind. Your enemy, the devil, prowls around like a roaring lion looking for someone to devour. That's from 1 Peter chapter 5, verse 8. Thank you very much.
Thank you very much, Dr. Panaligan. May we request the chair and co-chair, Dr. Remedios Coronel and Dr. Evelyn Rojas, to award the certificate of appreciation to our speaker. Let us give them a warm round of applause. We will now proceed to the Research Forum and Quiz Bowl. Please refer to the room assignments flashed on the screen. Thank you.